Welcome to Pediatric Nursing. Pediatric nursing to get here, we know how hard it is to get here. It is a hard course. You are going to have to put work in. And remember, children are not little people. Now, there are some similarities, but there's mostly differences. So we give you a lot of information, a lot of handouts. We have recordings. I have a YouTube recording that you can access at any time, and it's Professor Bogart, Pediatric Nursing. And this is going to be important because after tonight, Professor Morris is going to be teaching your class. There has been a last minute change this morning. We are trying to get campuses into sections, meet everyone's needs. So I'm in a different section and Professor Morris is taking this one over. So if you wanted to hear one of my recordings, Professor Bogart, Pediatric Nursing, and YouTube, and it's open, it's to the public. Also, you probably have heard, most of you, because you've been in Fortis, this is your almost second to last area till you get to capstone and you graduate. I do have Cahoots, and they are attached to the YouTube recordings there, so you can see it, or I send them to Professor Morris and she can give them to you, or message me and I will still give them to you. I still have full access to all of your information, your emails, etc. So I'm still very aware of what's going on. So you have all that information. Now, tonight, what we're going to do is we're going to go over the first PowerPoint, which is the rules, what to do, expectations, how to succeed, what do I want from you, what do you need to do to succeed in this course? Because our goal is we want no one to fail this course. I hate it when it happens. I feel bad. It's like, what could I have done differently? But I know that Professor Morris works hard. She tutors all the time. She really puts 100% in, and so do I. So if you fail, it's because maybe, you had 2 exams the same day, or maybe you didn't study as much as you could have, or you didn't listen the way we told you to study, because there is a trick to it. And we give you all the tools you need between their exam reviews, between the Cahoots that we give you, Hesi review, you should be successful. If you listen to us, you do watch them, and you are starting to understand. So remember, not just to memorize anymore, okay? You need to see a concept and to be able to apply it in any way. And with teaching it and then having the Cahoots, which you'll all have access to, you could test yourself for the day, okay? So let's first do the PowerPoint on, orientation online and what's going on. There are a few changes this semester. Then Professor Morris is going to leave us, and I still will teach you your first day. You'll have your first PowerPoint from me, your first Cahoots from me, and then from now on, you will be Professor Morris's class, okay? So any questions from anybody right now? Okay, let's go ahead and start with the first thing, which is the orientation PowerPoint. Now, you guys have all received the orientation. You have received the first week's PowerPoint. You've also received 2 handouts. The handouts, one was on vital signs and one was on theorists. So that's the information you've gotten from me this week. So let's go over this and say, all right, what's online learning? Well, online learning, we're trying to make it just like you are going to class with all the same things you do in class, but you're coming to a camera for 2.5 hours on a Friday night at 8 o'clock, okay? We know that if you are participating in class, we know that you're understanding more. It's felt that if you come to class prepared, at least take the new PowerPoint and they could be sent out, or the information we send you every week, and go over it and open the book and look at it. Come to class with an understanding of something going on, then being taught, and then with those PowerPoints, your time going, those Cahoots, go ahead and look through them and test yourself. We know that you will succeed here. Now, who do you contact? Well, the first person you're going to contact now is Professor Morris. If she's not giving you what you want, then I'm your second in line. You'll contact me. And you have my phone number. It's on the welcome now, but I'm going to give it to you again right here. It's 305-951-8055. And that's in case you have something you need to know right away. If it can wait a couple hours, I usually will respond the same day. I'm always checking my messages. It can go that way, but if you need it right away, you can text me, okay? Texting me is better than calling me because I don't know if you're a spam call. So just at least text me and I will answer you as quickly as I possibly can. Now, what if you don't like what I tell you, or I'm not answering you, and you need a message, you need an answer like, I want to know now? Call or text and email Darlene Brown. Be aware that her email is darlene.brown, not D Brown. Like mine is B Bogart and Professor Morris is C Morris. So darlene.brown, because there is another D Brown in Fortis organization. So be aware of that, okay? Call her, talk to her. It doesn't matter. Professor Morris won't be offended. I'm not going to be offended because she is there to support you too. If we're not getting what you want, our goal is to make sure you do. So you've got a number of people that you can go to and to be helped. So you know who to contact, you know how. You email or message us. That's the first thing. And that really actually puts a timestamp and something that we can show as, you know, they called us on the phone, but that's not really a timestamp. But if it's as an email or message in Canvas, it's like, oh, it was this time at this date, and we can show that you tried before a quiz, tried before exam, or something, and it can actually help you in the long run to do that message and also text, okay? So just be aware of that. And remember that as online, you know, it's difficult. It's difficult to be online. You've got, you know, all of these things in the background. You know, just try to be as courteous as possible. If you're coming in, you know, a little late, which it happens, which you know, today we're going to discuss why it shouldn't. But if it does, come in with your camera, your microphones off, so we don't come in with some screaming and yelling in the background and disturbing the class. So always being respectful, okay? Coming to class in a professional manner. Don't come into class in your jammies because it's 8 o'clock at night. You know, I feel like I want to do that too, but I'm not going to do it. You know, and just make sure that you're just not in a little, you know, a little shell that's sort of revealing. Okay. Part of the communication etiquette and etiquette, same thing. Always be respectful of the times. We're both Eastern Standard Time. Always use professional wordage, no slangs. And, you know, it's one thing I learned, you know, teaching and from my daughter, who's 37 now, is that if you put a message in all caps that you're yelling at them, because somehow I did it one day and she's like, why are you yelling at me, Mom? And I'm like, what do you mean? I'm not yelling at you. Anyway, so that's how I found it out. So please don't give me any all caps because I remember my daughter telling me stuff. Everything in this course is going to open up on Sunday night at 12 a.m. or Monday morning at 12:01 a.m. That's when things will open up, okay? And they're going to be due by 11:59 Pacific time on Sunday night. Now, discussion questions, and you do have one due this week. The first initial post is due on Wednesday, and then you have 2 peer reviews that are due by Sunday. Now, you will see Professor Morris will send you reminders. She's very good, and she starts on Saturday, even Thursday. She'll send, hey, I didn't hear your discussion question, get it in. She's really good with letting you know about those sort of things. So make sure, in doubt, look at the syllabus. When is it due? That's when it's programmed into your Canvas. So that is your Bible. Make sure you have a syllabus around. Now, work should all be turned in on time by 11:59 p.m. Pacific time. And if it's not, if something's happened to you, some event in life has happened, please just notify us before time. There are, you know, occasions where, you know, your kid ended up, you know, in the hospital, you're in the hospital, you had a car wreck, there's a snowstorm, no internet, there's hurricanes in Florida. I mean, many things can happen. Just let us know beforehand and we can work with you. We don't hear from you before something is due after Sunday night, it is late. And when it's late, it will be minus 10% deduction. And then you have till the following Sunday to get it in. We'll work with you, but you need to tell us beforehand. So communication is a key here. We can't figure out what's going on if you don't tell us. Now, attendance is not those attestations anymore, okay? You don't have to sign them. You're not going to be bothered about them. We're going to be doing it in class. So Zoom is a capability to see, even if you came in and out 4 or 5 times, we know what time you came in, what time you went out. If you left early, you came in late, we can see all of that. And it will be gone over to an Excel spreadsheet, and we can see that information, okay? Make sure you sign in with your full name known by Fortis. Very important. I'm saying it again. And be on time. You know, 3:01, 8:01, whatever your class time is, it is late. And for every 1 minute over, it's the whole 15 minutes because they take it in 15-minute increments is your attendance, okay? Now, very important that you get your attendance and you don't get time missing because you need a certain amount in order to achieve the grade that you're trying to earn. Again, make sure that you are posting in Canvas. If you're not posting in Canvas, as in your discussion questions, NCLEX questions, your case studies, it's going to show that you're not in attendance. So we will let you know if we need you to post, but please be aware of that. The attendance is taken every day. That's what Professor Morris was doing it, looking at it, checking it, making sure everybody was here. Again, it's going to be 15 minutes late if you're after time. Today is the only day we won't count you late, okay? The only day, unless you're 2 hours late and you didn't come for the class, okay? Very important. Now, if we're doing attendance and we're seeing these little 15 minutes before class, you're late. After class, you punch out early, okay? We will be taking off these 15 minutes, 15 minutes. It can count up and it could become an amount of time. What happens? Why is this important? Well, at 5% of the total hours that are due in the course, if you've been absent, you'll get a message, an email. If it gets up to 10%, you're going to be meeting with the instructor and you're going to be meeting with Dr. Brown, okay, to find out that, hey, you're getting late. At 15, it's 15%, you're going to meet with Dr. Brown and either the dean or the president of your campus to find out, because we're telling you, you are in jeopardy of being 20% late to your class. Once you get to 20% late, as in time missed, you will get a 1-letter grade deduction in your grade. So if you had an A, you're a B. If you're a B, you're a C. If you were a B plus, you're a C plus. But if you're like a B minus, now you're a C minus, and you could fail the grade. You could fail the course, which we do not want happening. That's why we're doing all this 5, 10, 15% to keep you aware of where you are in the attendance, okay? So every week, I want you to make sure that you go and see what's due. Most of you are in Med-Surg 2, community, and pediatrics. You've got a lot of stuff on your plate, and it's going to be extremely difficult, especially when it gets to week 7, 8, and 9. You're going to not remember what's going on, and you'll miss things. So make sure that you have a plan of how you're going to organize yourself. You keep organized, you're going to be okay. So whether it is taking one of those calendars on the desk, which I have, or something digital, or you have the syllabus is out and you just cross them out as you go, or digitally do it. I don't care how you do it, how you organize it. Make sure that you keep organized. Now, one of the things that you have to your benefit is if we're seeing something's not turned in, we'll send you reminders, usually Saturday, Sunday. You'll get them. Hey, you're going to be late, you know. Every case study is 1.25%. Every NCLEX question is 1.25%. You know, you don't want those amount of percentages off, especially if you're running it like a 79, 80 in the class. It could fail you. And we do not want that. So you'll be getting messages from them. So everything, turn it in as you can. Now, let's keep going here. So again, talk to the professors. If you don't talk to Professor Morris, talk to me, and we will work with you as much as we can, all right? Always make sure that your internet's reliable. Like we have one that's flecking up all over the place, you know, trying to work on something to make it better. As long as she can hear and she can be here, but you know, I don't want her flicking in and out and then you don't understand what's been going on in class. Make sure you come in your computer charged. And as we come into exams, make sure your cell phones are charged for that Zoom time, or at least have the charging cable that you can have it plugged in or have them both plugged in. Very, very important, okay? Try to be in a quiet place. And I know sometimes with 7 kids, it doesn't happen unless you lock yourself in a room somewhere, but try to keep yourself in an area where you can think, especially when you do quizzes and exams, okay? And assignments, make sure you read carefully what is due. Always come back and check into your course. You'll get important information sent to you on your announcements, telling you any important information that you need to know. So announcements are important. That's where you're going to get your recordings. That's where you're going to get messages maybe from the dean, or messages, something to look at, or something that you need to know about. Maybe what's going on with your Hesis and how they're scheduled. There'll be something there that's important. You know, Professor Morris doesn't write announcements just to write announcements to write announcements, because we know that 3 courses, announcements like that being sent, you're not going to read any of them. So just to know that, remember, we're not going to be crazy sending you announcements like that, okay? Again, make sure your stuff is done when it's due. Again, notify us if it's something that's going on. So hopefully for today, you have gone and you have looked at the syllabus. You've gone into Canvas, done the technology quiz, et cetera, et cetera. So you're ready to go. Make sure that you have done your ebook. Make sure you have it open. You know, we start at chapter 26 on your maternity textbook and go onward from there. And anything you're missing, please let us know. So when you come to class, I mean, a minimum, look through the information that Professor Morris sends to you, knowing what's going on. If you're not understanding anything, open the book and look at it. If you come to class prepared, and then you get your lecture on the things that are going on, I'll tell you, you will do a lot better in this course. Now, you got concepts that's over the head. I don't understand. I mean, I usually see this in the cardiac area. And I am more than willing to step in and really understand it for you, because that's my favorite love of life, is the pediatric cardiac intensive care unit. I can see blood pumping through my head. So if you need help with that, send me a message. I will tutor you. You know, just because I'm telling you Professor Morris is your professor now, doesn't mean that I've stepped back. I am lead pediatric professor and I'm always here for you, okay? Now, I know that Professor Morris has weekly tutoring sessions to get you through these times, you know, going over those concepts to make sure that you're understanding. Again, any technological problems, please notify Connie, Professor Morris, or me, so that we know what's going on and fill out a help ticket. And what would that mean? Well, you can't access a case study, or you can't open this or that, you know, or you did your case study and you don't see your grade except the 0 in the grade book. These are things you need to let us know so that we can follow through to make sure you do get those grades. So we don't do weekly review sessions, but We are here to do tutoring on a weekly basis with everyone. So whatever you need, you just let us know and we will work with you. We will be sending you all of the material that we cover in class, so you have a lot of information to go over. The grade is calculated by 80% of what we call key graded assessments, which is unit exam, quizzes, and your Hesi. And then we have that you have to get a 78.0. Once you achieve that, we will add in all of the homework stuff. And that can, really make your grade go up high if you have really done good grades with all of them. So 78 is your goal, that's minimum, and then we'll add in all your homework. And homework 20% will make a big difference. Now, we show you how homework can negatively or positively affect your grades. So we have them turned off for the first 5 weeks. Then we turn them on for about 2 weeks to let you know, to show you. And then on week 8, they're turned off. We will not turn them back on till after the Hesi's done and all of you have remediated. And your Hesi grades will not be posted into your grade book until all the remediation is done. So, and we can't turn it on, like, what's my grade, professor? Well, we can't turn on one person. So it will be after everybody has been done with the remediation. Again, 78 is what you need on the key graded assignments. And then after we get in the homework, you still have to maintain a 78. And you can and you will, and students have failed because they haven't done their homework. So don't be one of them. Get your homework done. Do not delay with it. Now, quizzes are going to be a part of classes now. They're not going to be online for you to do from Monday to Sunday. No, we're not doing that. But in order to get you in the groove of quizzes and what they're like and what you can expect on them, the first 2 quizzes, so quiz 1 and 2, are going to be done in class at the end. So you will be having a lecture first, and then we'll be doing your quiz at the end. So this class will be about 10 o'clock at night. You'll be doing your quiz, okay? And they will be proctored on Zoom, just like we do with exams. It's 1 attempt, it's 15 minutes. You go forward, not backwards, and it's 10 minutes, okay? So that is a difference in it, in this class, that we'll be doing quizzes in class. Quiz 3, 4, and 5 will be at the beginning of class. Any questions with that?
Yeah, I just have one question on the quizzes. Are they going to be through Canvas or will they be on Exemplify? Because I have
No,
2.
they're Canvas. They're on
Okay.
Canvas, and you go in through your modules. And another thing, they're all different quizzes this semester. They've all been changed. ExamSoft and exams through Exemplify, same thing. The one thing I want you to be aware of, because I've had students like almost have hypertensive reactions and strokes because they can't upload their exam, or all of a sudden in the middle of it, your computer stopped out and you can't get back in. You're afraid exams are lost. I want you to know, once you've entered a question in ExamSoft and Exemplify, it'll be there. We can go back and we can retrieve these. Now, if you're ever having a problem during exam, and I've had it done before, where all of a sudden the internet went out and they couldn't get back on, immediately notify Professor Morris. Let her know what's going on. That'll be a timestamp in your email or in your Canvas, okay? So we know timestamp. We can look back on quizzes and exam every stroke of any button that you touch. So we have a time for everything there. So we can validate, yes, she sent me this message. Yes, this is the time the exam went off. We know that's exactly, we can validate what you've said, okay? So again, they're never lost. We can, depending on the times, get you back in or not, or we can push it back. This night probably will be on the weekend or the beginning of the following week to get it done. and we can restart you where you left off. So just to let you know, any problems with these programs, let us know immediately. Stop it. Don't try to go ahead. Don't try to, you see an internet stuff going on, just stop the exam. Just let us know, okay? Because remember, they are timed, and I don't want you to run out of time trying to play with different things that are going on. Exams. All exams will be held at class time. We know it's going to be on Zoom, all the same things. Now, what if something that you can't attend an exam that day? You're in the hospital, you know, you've had a death in the family. I mean, there's been so many things that gone on, I can't even explain the amount of different stuff that's happened to students. You need to tell the professor before the exam starts, before class time. It needs to be time-stamped again before your exam. If it's something you know a day or two ahead of time, please let Professor Morris know. Now, if there's an exam and you just don't show up, you will be told to take the exam at a later time, and it will be a minus 10% deduction that will be done. So again, what can I tell you? Talk to your professor. We will work with you if we know what's going on. I know that some of you like proctored on campus. It must be beforehand, 72 hours before the exam, that we can validate who's going to be doing the proctoring, because we have to send the access code to them because they don't have it without us doing it for them, okay? Very important that we know what's going on. And remember, it must be during class time. Also, there is class after every exam. You must at that time then come back to class to get attendance, okay? Very important. So if you're not taking the exam for your internet don't work, you have too many kids, you need quiet, whatever the setting, or you're already at school, it's too far to go home to make it on time, whatever, please, please come back to class when you're done. Yeah, Jamie, you had a question?
Yeah, sorry. For proctoring, so we're not using the ProctorU, right? We're just doing proctoring on Zoom.
Zoom. ProctorU is only used for the Hesi, and we only used it for 2 colleges last term. So all exams, all quizzes are done. Well, exams are done, exemplify, quizzes are done in Canvas through the modules. Okay.
Perfect. Thank you.
Always know with exams, we will be checking your IDs. It's either driver's license or your Fortis ID. We will be looking at your environments, nothing in your ears. We need to see what's going on there. You know, I've had the most craziest things happen where students got earbuds, and of course the mics are off and they're talking to someone and someone's answering, giving them questions to answers. I mean, they've had iPhone watches hidden places. I could go on and on and on. And all I can say is all you're doing is cheating yourself if you think, you know, that has to be done. So please be responsible, and, you know, you don't have to get an A on every grade. You know, I graduated nursing school with a C. Okay. I'm not the biggest, brightest person when it came to nursing school. Now, since that, BSN, MSN, PhD, I have a 4.0 GPA, but I barely got through nursing school. It didn't mean I'm not a good nurse, because I'm probably one of the best nurses you'll ever meet, because I took it seriously. And I'm like, I worked hard. Yeah, my grades weren't good, but I earned every single grade I got, okay? So just remember that. And I know it's hard. I know it's rough. I know you got 3 courses out there, most of you, but just put in your best. And again, talk to your professor if you need help, okay? So again, exams unless prior notification is a 0, and there is that penalty. Again, if it's an emergency that's going on, we will want the documentation, death and family in the hospital, in the ER, whatever. Just give us that information if we can have it. Again, communication is before, not after. Same thing I've said. Again, contact us, contact us, contact us. How many times did I say it? At least 10 already? Okay, I think you understand. So homework assignments. Again, look at your syllabus, get yourself organized and get it done when it's due. I don't care how you organize it, just get it organized. Again, if you're gonna be late for a valid reason, not every week. Now, every week it can't happen, but let's say 1 week, 6 of your 7 kids are sick and you're up to here and you just can't. Well, let us know. All right, we can work with you. You're sick, you're having whatever, you've got, the flu, you've got COVID and you're sick, you can't lift your head. Just let us know. We'll work with you. But if you tell us nothing and you're late, you will have a 10% deduction. Okay. So please, again, communicate. NCLEX questions. Now, make sure you go through the modules. There's sets of 50 and there's topics what to cover. Be careful. The first week is on growth and development. It's not in the pediatric section. Above it is growth and development, okay? Make sure also that they are sent in the proper format. If you don't have the proper format, Professor Morris will work with you, or we can send you an instruction sheet, which I have, Professor Morris, and I can send it to you. It has instructions on how to break it down and how to do it easy. We want that 5-page handout, whatever it is. The NCLEX can be whatever score you want it to be. You can do it over and over till you get your 50 out of 50, which is your 100, or you can turn in a 34 out of 50, whatever you want. But remember, these can negatively or positively affect your final grade. So whatever you do, and your NCLEX questions are open, which means you can go in and look at topics right now. But I'll warn you, do not submit until the week that they're due, because again, you need points of contact in Canvas, okay? That's what all I said. Case studies, exams. Now, you have burns due on week 3. The way that your stuff is set up is that, let me see, burns is due week 3. We have it opening up next Monday at 12 a.m., going through the week after week 3 to week 4 at the end. But you will see a due date for week 3 on that Sunday night, okay? So do you hear me? A week before and a week after it's due, you have your case studies open. So that's the earliest we'll open them for you, because we don't want you to get too far ahead, because we want you to do those case studies when we're going over these subjects, okay? So it's important. And again, all these case studies, you must go through modules. If you try to go in through Evolve, it's going to show a 0 when you try to go in through the modules. There are very, very rare cases that you might have approval from the Dean of Nursing, okay? But I've only seen one in my lifetime, okay? All your case studies should automatically reflect in your grade book. If you are not seeing it, you need to let Professor Morris know, and you need to send in a help ticket, okay? That will get us working on it. Now, because you have a 0, don't worry, your work is not missing. It's still there somewhere. We just have to know where to go and to look for it, okay? So, but let us know so that we can retrieve this for you so you can get your earned grades. Because again, each case study, 1%, okay? You don't want to miss that. Now, you have one big project worth 6% due in week 8 in pediatrics. And this is a 3-part thing that we have developed. It's about a diagnosis in pediatrics that you choose. You need prior authorization from Professor Morris to do a subject. The first part is 250 words, APA paper, that means 2 references minimum, that you tell me what is that diagnosis, okay? The second part is an assessment, and the assessment must reflect what the diagnosis is. If you're talking about something like asthma, you better give me the lungs with expiratory wheezing and retractions and tachypnea and tachycardia. I want to hear all those things, right? Because it reflects your diagnosis. And then the third thing is teach me something. You could teach me how to feed a baby that with reflux. You can teach me how to prevent urinary tract infections. 5 slides on a PowerPoint, a pamphlet, or a picture board. Again, put a reference on those teachings. I think teaching is what pediatrics is all about. We are family-centered care. It's teaching parents how do you take care of kids. And don't ever assume because you have a lot of kids that you understand everything. Don't think the parent knows more than you. You need to teach. And even if they're medical, still teach them, because not every nurse is a pediatric person. Just like, I just happen to be a weird person. I'm adult peds, but most people choose one area and they don't know the other. So teaching, important. You're going to always follow the rubric. As we get closer, any questions, Professor Morris will go over it. Remember, it is APA, and this is something that's also opened early. If you want to submit this early, okay, you can submit it to Professor Morris. She'll look at it, tell you if there's any issues with it, and she can help you get a better grade. Like you didn't do this, and that on it, and you can change it. So if you do it early, you have better chances for a better grade. Again, exams and quizzes, they are timed. Know that. And again, any problems, stop right away. Let us know, because we can look at, there's places that we can look that we say, oh, they answered it this many times and this seconds in between. Oops, then there's nothing, cut off, internet. It'll tell us what's going on. So just let us know. Hesi's, there is Hesi reviews. I actually have 2 100 Kahoots that you'll be getting. And you know that even with exams, we have 4 pediatric professors this semester. We have Professor Arstenstall, Professor Gullett, Professor Morris, and myself. We will be posting reviews that you can come attend live, or we'll be posting the recordings. Make at least 2 of them so that you see 2 points of view on the same subject. It will help you understand some things that maybe you weren't that keen on, that you didn't get it that well, okay? Know that your Hesi is 20%. And, with all of the things that we've been doing in pediatrics, our mean scores are well over 900 on the Hesi, which I think is quite amazing, because pediatrics is not easy. It is a Med-Surg 2 level course, but it's on children. Remediation is the same. Remember, you don't get Hesi grades until your remediation is completed. And I'm telling you, you're going to get little reminders from Professor Morris. I don't see a remediation. It's due in 4 hours, and you will get stuff like that. Okay. It's due tomorrow. Remember this, and just say, okay, I hear you. Send a message back. Remember with it, exemplify, you need to do all your things with, if you're Proctor U, you're going to need these things, or even in your on ground, you need to show who you are. There's all of these review and questions here. All I wanted to tell you about is pediatrics, and our program is based upon how are you going to function as a nurse. You are given a nurse and you're given an assignment with treatments and medications to do, and this many patients or clients, whatever you want to call. That what is nursing school all about? You're given a syllabus and you're given tasks and things to do, and you have to do them in a timely fashion, just like nursing. And we know that communication with your charge nurse, with the physician, is important. Same thing, it's being accountable, just like you would be when you all become such incredible RNs. Any questions? Put you to sleep yet? Not yet? Okay, Professor Morris, good night. I'm going to put on my PowerPoint, and then we're going to go on to the Kahoots, and I'm going to test you right after, okay?
I will see y'all next week.
And she'll be sending the Zoom links and how to get there. You're getting all that information in your announcements. It'll also be on the contact information about your professor.
And I'll be sending you some other lecture notes and stuff too from my class that I did this week. So I'll see y'all next Friday. Have a good week. Have a good weekend. Go Jaguars.
Yeah, she's from up North Florida. Okay.
Professor Boger, I do have a question. Are you teaching any other pediatric classes, or are you just not teaching peds at all?
No, I am teaching Monday and Wednesday, 3 to 5:30, and I'm teaching PN courses, and I'm revamping the whole PN course this semester. So I have 2 RN courses and I have a PN course. Now, I know a lot of you are happy. I know you like, you've heard things about me. As I said, you have all access to all of my information. You'll have access to my PowerPoints. You'll have access to my Kahoots. You'll have access to my recordings. They're there. They're for you. Use them. And I'll tell you, going to Professor Morris' class, she's thorough, very thorough, more than I. And then you can listen to my recording and I break it down and simplify. I'll tell you, you guys will do incredible. Okay. So just to tell you that. Okay, we're going to go over chapters 26 through 30. A lot of information. I'm going to go over those highlights within them. Now, healthy care for children. Now, back in 2010, when I started back into school, they started talking about Healthy People 2010. And what it is the government puts down these things that they want to look at or help or monitor to see what's going on in all of these different health disparities, children, elderly, homeless, etc. But what they did in Healthy People 30 in that pediatric area is looking at family support, making sure family has all the things they need to take care of children, looking at growth development, mental health in children. Now you think mental health, children doesn't go hand in hand. Well, I'm telling you, you have young children. I saw one boy that was one of our frequent children in the emergency room. He had severe schizophrenia. And he was real. It was not a fake. It wasn't a spoiled child having a fit. It was none of that. And this kid really suffered because as he got older, he had to keep changing the dosage of medications, and then of course, bodies changes. He had to keep changing medications too. So mental health is true and real when you're talking about children. Nutrition, 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 nutrition. I think the most important thing that we do for all age of our population. I mean, think about your infant. Born at 7 pounds, and by 1 year old, they are 21 pounds. At birth, they can't lift a head. And by 1 year old, according to the book, they should be walking. Can you imagine how much nutrition to support the brain, the nerves, and the muscles on these children must take? So nutrition, nutrition, nutrition. Most important thing when we think about in taking care of our children. A healthy weight, not too skinny, not too fat, right? Keeping them active. Oral health. If you don't have teeth that are good and they hurt, are you going to eat? Are you going to have proper nutrition? Think of it that way. So healthy sexual development, getting into your teenagers and your adolescents in any age, safety, injury preventions, and then of course, knowing what's out in the community that can help you. Big health problem in pediatrics is diabetes because of obesity. You have children that today are more sedentary than ever. Just think about it. You've got children, well, some of them are born in neighborhoods they can't go outside or they don't have a backyard. They live in a, just an apartment and there is no area and it's not safe. So they got to keep inside. But other children, they have iPads and they have new Nintendo Switch game and, they have their phones and they're playing with electronics versus going out and being active. Big, big problem. And what that does, it has children gaining weight there. Also, if you consider it today, 2 parents need to work in order to support a family. And many times it's go through the drive-in, pick up some food to bring it home for dinner because there was no other time, no other choice. And we know that fast food can have a lot more calories and fat, et cetera, in it. It's no fault to anybody. It's just a reality of life. violence, whether it's bullying, whether it's gangs as they're in the adolescents. And the newer one that's here is vaping epidemic. You know, a lot of the teenagers are vaping, you know, they like their marijuana on their vape because they think they're smoking a cigarette, right? Nobody can tell. So vaping, but it's a big thing and it's not a good thing. And again, we talked about mental health. Some pictures to depict some things. I think for me in South Florida, it's all about swimming and drowning. Seen quite a few. I've even seen a physician's child drown and end up, you know, brain dead almost. I mean, end up, you know, they needed a G tube and they didn't do much in the end. So it can happen. You know, I've got a grandson who's 6. That kid at age 2 is doing front flips off the ladder because I taught that child right away. But he'll never, ever go in the pool without asking, Nana, can I go in the pool, please? Because I don't care how good this kid is. I want to watch because things happen. Because, you know, he's now 6, but he could jump off, bop his head, and be unconscious and sink to the bottom, right? So we make sure that those things are safe. I had a brother who pulled a frying pan off and burnt with grease one of his arms where he had scars for his life. And of course, we know they get into pills. They love Flintstone vitamins. They like those chewable ibuprofen and acetaminophen too. And of course, those are more problems, but the Flintstone vitamins, as long as there's no iron, they do well. And of course, we know guns, adolescents for sure. And then of course, suffocation things. So the highest risk children in health problems are those born small. You know, they're born before they should be born. They could be 24, 25 weeks. They're born instead of 40, right? Those are your premature. The very low birth weight or the low birth weight children. Kids who attend daycare. Well, think about daycare. All these kids in a room, what do they do all day? They play, right? And it's one toy handed from this kid to that kid to that kid. I call it swapping spit all day long. So if one kid is sick, let me tell you, it's going to go through all of them because they explore the world in their mouth. So you'll see that with daycares. Poverty and homeless, they're not getting proper nutrition. You know, they're not getting proper even hygiene, a lot of them. So it creates problems. Immigrant families, I think of all of the patients, the children that have come into the emergency room, I think the ones that scared me the most are from the migrant workers that come in because they're afraid to come in, number one, because they might be deported. And that's not our goal in medical care, is to treat the child, right? But they don't know that, they're afraid. And they're really sick by the time they come in. I've seen kids, bilateral ear infections, bilateral pneumonias, and they didn't come in until they're at that point with 105 fevers because they're afraid that they're going to be deported or whatever. Children with chronic medical and psychiatric illnesses and disability, it's a big health problem. It's a big demand on the community and on the families. And we know that there is health care. All this care is available, but getting to it, do they have transportation? Do they have the $5 deductible to see that physician? And many of the time the answer is no. So these are things that do make those barriers there. Now, infant mortality is when you have children that are born from 30 days to 1 year old. The neonatal is up to that 28 days, and those have the most of all of the deaths in children. You know, if an infant's going to die, it's usually in the first 28 days, but they can die up to the first year. That's the largest number of children who do die. Now, United States, wonderful country, right? We're so progressive, we know everything. Well, we lag behind other nations in deaths. We have more deaths here in the United States of these children than some other countries. I think the one that comes to mind that I've watched some documentary about is Switzerland, that their healthcare, that with the World Health Organization, that they have one of the best infant death mortality rates. So we're getting there. I've seen so many changes, but we have a lot more that we need to do. We know one of the variables is that weight. What were they born? What was their weight at birth? It could be 500 grams. It's not even a pound. You can have a 24-weeker born at that. Usually they're born around between 500 and 600 grams, which is right at a pound. 24 weeks, their eyes are fused shut, their skin is red and gelatinous. This kid right there, that little picture is probably a 26 weeker. Still pink, still the skin, you still can see through it, but a little bit more. I think his eyes are already open too, because usually they're not. As they get older, the mortality rate does go down, and most of their mortalities is due to unintentional accidents. And I can tell you that's usually due to car accidents, whether they're in the car, in their car seats, or they're ran over by a car. As they get older, you'll see the lowest death rate. Children become more of a conscious, more aware. But when they get to be in adolescence, now they're the know-it-alls then, and they want to explore, and they're old enough now, they get more privileges, so they have more injuries. They're driving cars now, right? Driving cars, whether they're hit or they hit someone else. And then homicide, look at firearms. They start to explore what they are. And suicide is a big thing with adolescents, because adolescents are exploring for their identity. And it's also about their body image. Too many pimples, too fat, too skinny, hair too curly, whatever it is, and that body image just makes a big thing. Increased morbidity, again, homeless, poverty, low birth weight, chronic illness, etc. So children, we wish none of them died. We do that, but it's going to happen. And I'll tell you the one thing about children dying, it's not that they died, it's what did you do for that child and that family while that child was alive? Because I've got lifelong friends from children who passed away over 20 years ago. I'm still in contact with those parents. So it does make a difference, you as a nurse. And it just takes being sometimes a listener, sometimes a hug, or crying with them. I've cried with many of parents, and it's okay. You're allowed to do that. You don't have to be this tough guy, because I'm not. I cry at cartoons. So pediatric care is family-centered care. It means that you must think about not only the child, but you have to think about the family. The family needs to be involved in the whole thing. The family are your ears and eyes, especially mom and dad. You could have 4, 5, 6 children if you're working on a pediatric floor. How are you going to know what's going on with all of those children at the same time? Parents, teach them what you need. Teach them what has to be done, what to look for, good things, bad things, or when to notify you. And let me tell you, they're your best ears and eyes you can have, because it's their kid. They're just staring at them, watching them. Now, there's all types of families today. And what is a family? Well, it's whatever you think it is. Well, my family is me and my husband and both of our children, and we're a blended family. And that's okay, and we work well with it. It could be 2 women, 2 men. It could be just a man, just a woman, single parents. It could be adoptive parents. It could be grandparents. It could be aunts, uncles that took their children. It don't matter. A family is whatever the individual thinks it is, they consider it. Now, pediatric nursing, let me tell you, you're going to be philosophers. I think one of the things that turns students and new nurses against pediatrics is that you have to work with the parents, and you have to realize parents are just concerned. They want the best for their children, and they can't have the best for their children, sometimes because they're both yelling at each other. So you become like the coach in between. And I've been there quite a few times also. So teaching them health prevention, injury prevention, what to look for, looking for things that are going on, if this is going to happen, look for this and this, and then what you need to do and who do you notify. All of these things we need to teach. Now, children tend to be afraid of nurses and doctors, especially in the first 2 or 3 years of life. Because what do we do mostly every time we see a child, a nurse, when we see them? We're giving them an injection, usually immunizations, right? So they're like, nope, she's coming for me. So they're afraid. So what we try to do today is what we call atraumatic care. doing everything we can to decrease the amount of pain that's delivered to a child in any given procedure. Now, in my PhD, I developed a program, and it's still used today at the big pediatric healthcare system here in South Florida, Nicholas Children's Hospital, and it's something called Huggies, H period, U period, G period, G period, etc. Help us give great injections efficiently and safely. And what I proposed and did research on is that if a child was held during an injection, before, during, and after, there was less fear, less pain, and less stress, as evidenced by less crying. So I proved it, and it does work. So Nicholas Children's all about comfort care. That's their theorist, Catherine Kaba, which is another theorist that you don't have to worry about. But she promotes all about comfort. So I promote parental comfort holding, which is holding your child for injections. And it has been proven to work. We can suture heads, we can stitch on fingers that are falling off, we can do all sorts of things if a parent holds their child. Can you imagine? We used to take the child out of the parent's arms, put him, lay him down on a stretcher. Somebody holds their arms, somebody holds their knees, and I jab an an injection in them. That's what used to be done. I think it's barbaric. So having a parent hold, a nurse just holding the arm or the leg, wherever it's going to go, so I can give it without the child moving, that child, it's not going to be as frightened. And that helps with psychological and physical distress, right? So it's always first do no harm. There's no harm in a parent's arms. So culture, family, what's going on? As I said, there's all types of families. I don't need to name them all. There's lots of them. Understanding the family and the functioning can help you take care of the child. Like, who is the mom? Who's the dad? Who's the speaker for that child? Who knows the most? And then you can get them what they do need. So if we're going to understand our family, which is our child, sometimes cultural religious influences make a difference on the way we approach the child or the family and how we get acknowledged. I mean, if I don't know something about a culture, and I can see it's not something I know about, I'm just going to ask, is there anything special you need from me? Do you have special diet? Do you have special times, for your religious things that you do? Let me tell you, a family, a parent will be really pleased that you asked the question, because now you are acknowledging them as a person, and making room for them to do those things that make them feel better and what they feel makes the baby better. Okay. Now, sometimes it's race, it's ethnicity that we see in children. So again, understanding it, there's all sorts of social culture, it's called. It's again, where do they come in, from? You look at their eye. Is a girl patient have to have a woman nurse, not a man? All of these things make a difference. So understanding those things do help. So a frequent health problem in migrant children and adolescents in the United States is, you get a migrant child who comes here. What's one thing that we're really concerned about? Anybody?
Tuberculosis.
Absolutely. In the United States, we have all of these testings, etc., and we have it mostly wiped out. But remember, these children come from countries that they don't have all of the medical treatments that we do have here. So it is something to be considered about. And if it is a migrant worker, I, as a nurse, I'm going to put on a mask just to be safe. Now, I tend to be autoimmune. I take infusions because I have rheumatoid arthritis. But even before that, before I knew, I would wear a mask. Keep yourself safe. So be aware that some cultures treat the body and themselves differently, the way they think about things. They have special foods, maybe no only vegetarian, maybe certain things they don't, maybe they have to have certain coverings on their body. Medicines could be all sorts of herbal medicines. You know, my husband is Jamaican, and there's all sorts of garlic and ginger teas and all of these salves and poultices and stuff that he uses. We need to be aware of that because they're still going to be using them, and we want to make sure it doesn't interfere with our medical care. There's also people that believe in different things, like if you go out in the rain, you're going to get wet, right? So you don't go out in the rain, you can't get wet. Or I was actually in an adult facility during this one. I was in the surgical ICU and I was pregnant at the time. So it's a long time ago, but I'll remember it as ever. They pulled the curtain and wanted to take chicken blood in a bowl and do something voodoo thing on this patient. But they said to me, please put a quarter on your belly button and tape it on because I don't want evil spirits entering your body. Well, the crazy, and I let them do whatever because it didn't hurt the patient at all. You know, the client was an older man who just had surgery and it was extensive and he wasn't doing good. The next day, this guy turned around and did better and walked out of the hospital. So does it work? Come on. I don't know. Was it medical care or was it that whatever care you want to call it? But it's as long as it doesn't affect your care, who cares what they do, right? If they believe in it, makes them feel better, that's what I want. How about things about hot and cold? Well, you know, many cultures, I mean, working here in South Florida, you'll see children coming into the emergency room with a fever. You'll see them with a hat on. You'll see them on 3 onesies. They'll also have on a coat, the shoes, socks, wrapped in a heavy blanket, and their fever's 104. And you're like, okay, let me explain something about hot and cold to you. So if you have a fever and you cover it up, how's that fever going to go away? It can't. So let's take some of these clothes off. So let the fever go away. Another thing I'd have to say is when they get home, please take their socks off. They can walk on the tile floor in bare feet because that coolness from the floor is going to decrease their fever. And when their fevers are down, they're going to eat and drink and be happier and play. I mean, the Hispanic population, grandma, put the socks on your feet to walk on those tile floors. So that's understanding the culture of the patients where I worked. And you'll find that in wherever you are, there's going to be different cultures, and it's understanding that. And what have I done? I've helped a child, right? My goal is to help a child. Religious beliefs. I think the one that I can describe this the best is with Jehovah's Witness. Now, Jehovah's Witness tend to believe of no blood or blood products because the blood makes their soul bad or something of the sort. And it's really something they firmly believe in. So you have a premature baby born, they're not making their own blood cells yet. And you're going to be taking blood to monitor electrolytes and their CBC, et cetera. I mean, it's only 1 ml a day, but it adds up, especially if the child only weighs, you know, 1.5 pounds. So many times we need to give blood to them. You will not get a parent to sign the consent for blood. So you will have a court order done for them. And the parents are aware of it. They know it. But you have to give blood to a child who parents don't want to give it. So how do you do it? Well, number one, respect the parents. It's their belief. So don't have that blood bag in their face and showing it to them. I worked night shift for many years. So I say, when you go home tonight, I'll take care of this. Call me at this time. I'll be done and let you know how your baby did. If I'm doing the day shift, which I did also, I will have the parent step out of the room, close the curtains. I will hang up the blood, put it on a machine, and I'll cover it up with a blanket. So, and I'll take the bag. Nothing blood is going to be sitting there when they walk back in that room. And I've had parents 17 years later come to me and tell me how I made them feel like they were important and their beliefs were important because I respected them. One of my last days working in the ER, I found a kid. He was almost 18 years old, and he was one of the kids that I remember twice giving a blood transfusion to, who was a Jehovah's Witness. And I did exactly those things for that child. And the mother said, you know, I've been looking for you for a long time. And she said, I just want to thank you and give you a hug. And she said to the child, this is Betty Boop. This is the nurse I've always told you about, because I was known as Betty Boop, because you're not going to forget that name, right? Nancy, Linda, Sharon, you're going to forget that. But Betty Boop, you'll remember it. So again, pediatric nursing is all about support and counseling. It's also about helping to coordinate activities for children, getting them the care they need, the insurance they need, the resources. You know, we are an all-doer people in pediatrics, taking care of child and families. So the leading cause of death among African-American boys, ages 15 to 19 is which one?
Prior,
That's right. They're getting into being experienced and, you know, I'm cool. Let me shoot it up in the air, right? Yeah, it happens, and it's just part of adolescence behavior. They get into risk-taking behavior, it's called. So genetics, growth, development. Now, what is amazing is when you get a newborn that can't even lift his head at birth, by 1 year old, that this child now can walk, and what they had to go through to get there, all the fine motor skills and the gross motor skills. It's interrelated, simultaneous, and ongoing. And sometimes it's not, you see it right away. It's slowly that you'll see them. They'll try to turn from their belly to their back, and then they try to go from their back to their belly. And then they try to get on their knees, and they crawl backwards and front ways. And then they're trying to sit up, and then they start to creep, you know, around the couch or the coffee table. And then all of a sudden they're walking. And it just happens. It's slow. It's not abrupt, sudden. It's an interrelated, simultaneous, it's ongoing. And I just wrote what development and all of these things mean. It's just basically, you know, you grow and then you mature mentally also. So there are stages and there's patterns of growth and development. There's a directional trend, there is sequential trend, developmental pace, and sensitive periods. These are all in your beginning of vocabularies of your chapter, something to look at. But to give you an example, sequential trend is, we know that you'll lift your head up before you roll over. You know that you are going to probably get up on your knees before you walk. I mean, these are before. You may skip steps, but we know one thing is going to happen and the next is going to happen. Their metabolism at birth. I mean, you've seen the handouts that I've given you on vital signs. A newborn infant at birth, heart rate's going to be 140 to 160 at sleep. Now, by the time they're 1 year old, it's 100 to like 118, 120. But as they get older, as we get to be adults, what, 60 to 100, right? And the respiratory rate's different. Blood pressures are higher. Blood pressures at birth could be 60 over 40. By 1 year, it could be 90 over 60. We know when they're born, the first thing we do is take and put a hat on them and put it underneath a warmer. We give them heat, right? Because there's nothing to keep them from losing their heat. There's no fatty tissue. Okay, they're born and they've been soaked in amniotic fluid. They need to lose that fluid and they lose their weight, their temperature right away. And we don't want to chill that child. They sleep a lot, hopefully up to 4 hours stretches if they're just a full-term infant. And again, nutrition, 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 the single most important influence on their health. We know that children have all different temperaments. We know there's easy, difficult, and slow to warm up kids. I think this is why I love children so much, because I like to see which kid is going to be what. You know, I think a lot of it has to do with, you know, that easy, happy child is the one that all needs have been met all the time when they were growing up in the first year of life. And sometimes the difficult children, maybe there was a loud, you know, type of environment, or maybe pregnancy stuff was going on. And then of course you have those kids who are shy and they're always scared of everybody. I think I like to get to those kids and I like to warm up and gain their trust. I think that gives me, makes me feel pretty good. There's all different types of theorists. We're going to be going over this mostly during when we go to infants, toddlers, and preschool next week. But the ones that you need to know is Freud, Erikson, Piaget, and Kohlberg. Fowler, we don't go in as much. So just those first four. Freud is all about oral, anal, sexual. Okay. The one thing that Freud says is oral is birth, which means infants at birth, they self-soothe by their mouths. So pacifiers are so important. They'll even take fingers. They explore the world. Everything goes in their mouth. Even as they get older, aren't they always something in their mouth? I told you the toddlers, daycare, everything. My 6-year-old grandson just turned six on Monday. I mean, he's still today, his teeth, his shirt, everything in the mouth, in the mouth. I mean, it's all exploring through that. Freud, there's different things that we'll be going over. I mean, the one I'll start you off with is trust versus mistrust, and that's at birth. Trust means that infants' needs are always met. My baby cries, I go get him, I feed him, I change him, I burp him, I do what his needs are. And that forms trust. The infant who mistrusts means that their needs aren't being met and they cry and nobody goes for them. And that could be, you know, just a dysfunctional family, you know, could be some sort of substance abuse or alcohol or something in there, or just abuse itself. So that could form mistrust, but we want to have that trust with that infant. When we talk about Piaget, he's all about mind development, as in you took a rattle, you took a grasp, you got a hold of it, and all of a sudden you shook it and it made a noise. And then you go back and you do it again. It's like he didn't know that before he grasped the rattle and it somehow moved and he heard something rattle. He's like, oh, it does something. So he does it again. It's learning, it's cognition, it's critically thinking, it's figuring things out. We know that language starts with cooing and crying, and then it goes on from there as we need to, as they get smarter. Kohlberg, good and bad, and a consequence for either. Something as they get older, you know, they want to do good all the time. And some kids need to do bad. They want to do something bad because they gotta, but they know what the consequence is. And like, okay, I gotta do it, but I know I'm gonna have a consequence. That's your older kids. But your younger kids are trying to be good. They're trying to do good things. They're learning what's right, what's wrong. They want to please. You know, I went to work for, I don't know, 25 years in pediatrics. And I went to work and I played every single day that I was there. Yes, I worked in intensive care units, but I went and I played every single day. And that's what children do every single day. They play together, they play because of textures, they play because they're by themselves, or they're pretending, they play games, whatever it is they play. They play because they want to feel what these things feel like, sensor or motor. What does it feel like? Put it in the mouth and then move it around. What does it do? Does it vroom, vroom like a car? This makes the intelligence grow. It also works with socialization, creativity, and it makes them aware of their environment around them. Now, there are types of play. You know, when you are a toddler, you're probably going to be in more of a parallel play. You'll be playing at the same place. You're playing with your toys, but you're not really paying attention to each other, but you're both playing. You don't mind that they're there. Okay, solitary, you're alone, or you're watching someone onlooker. Associative, you're playing together, but there's no goal. Okay, you're just playing with toys and blocks and together and whatever, but there's like no end to the play. There's no winning. Now, cooperative play is you're playing together, but there is a goal in the end, like playing a game of checkers. Whoever gets all the checkers off wins, right? Whoever has the last king, whatever, they win. Toys do support children's cognition and enhances their development. And it also gives a time where parents and children can sit and play together and bond. It also helps a child like reach for toys, pulling, rolling, manipulating its muscles, its movements, it's all those things that they need to do. Now, developmental assessments. There's all sorts of screening procedures, forms, et cetera, in every hospital, whatever. And there are objective measurements that you will always do on kids, whether a doctor's office, an urgent care, ER. Remember, every kid that comes into one of these places, all are going to have a height and a weight. And we measure that. And we know children are always growing. And why do we do height and weight? Well, they don't weigh enough, cognition, they're not going to be where we need. Or maybe if they're way too tall, maybe there's a growth hormone that's too much, or maybe a pituitary tumor, right? Something's wrong. So we are really measuring. Could be something to do with your thyroid. It could be something to do with anything. So measurements are so important. Making sure that we are assessing children with disabilities, that we get on their level, okay? Children with disabilities like cerebral palsy, like this bottom left girl here, they can talk to you in their way. You just gotta say, all right, what is she trying to tell me? And we can look at like facial expressions, or, you know, are they crying? Are they holding their tummy? Are they rocking? Even if they're nonverbal, they can tell you. Children are born with congenital abnormalities, from a cleft lip up to some sort of syndrome. And we know that making sure that we as nurses, you know, those things that we can identify. Sometimes it's us looking at kids saying, I think something's wrong here, you know, and asking the physician. And sometimes the physician goes, maybe it could be. It could be due to chemicals, infections, et cetera, or it could be genetics. And there's all different sort of chromosome abnormalities. I mean, you think of genetics, you think of Down syndrome, right? It could be chromosome 18, could be 21, 18, 15, 11, or 9, to tell you the truth. And the smaller the number, the more severe their Downs is. Q22 deletion syndromes, the George syndrome, and all these things have different things that you need to look for. So we need to understand that to be able to take care of their kids. If I have that Q22 deletion, the George child, I know they might have trouble with speech or eating or swallowing, and they're going to have problems with calcium, and they could have a cardiac condition. So I'm going to make sure that I'm looking for that, being a nurse. You need to understand those things. You know, you're going to have parents. I mean, I think I saw it the most in the cardiac ICU, you know, for children, where, you know, you see the mother going, why did I take that Tylenol when I was 3 weeks pregnant? And you have to say, Mom, it's nothing you did wrong. You know, they just feel that, what did I do? How did I cause this? You know, most of the time, it's just a happenstance. It's, if you understood how the body, there's a stalk and it turns and twists, it comes up and goes over, you'd be surprised how more hearts weren't disformed. So taking a child, if you can, and putting the parent, sitting them in a chair and wrapping them up and putting that child in their arms to say, wow, now if they had a cleft lip and they're worried about that, say, oh my God, look at those cheeks, all that hair, they got so much hair. Focus it on something else. Promote that bonding so that they have that together. That's an attachment they need. Now, this is a question on stuff we're going to go over more next week, but I'm just introducing it to you. And it's basically just the terms: object permanence, pre-operational, concrete, operational, and how to use abstract symbols. We know, you don't know yet, but pre-operational, concrete, operational are about Piaget and cognitive thinking. Now, object permanence is something children learn as infants. You take a toy and you show the infant, and then you put it behind something. As they get older, they'll know that I saw it, even though I can't see it now, it's here somewhere, and they go reaching for it. So object permanence. You have the 1-year-old, you put everything in the toy box. You think they don't know where it's at. and they go to the toy box and they pull out whatever they want, right? Object permanence. And then again, this was all about having a bunch of different stuff to organize it. It was actually concrete operations, and we're going to go into that more again next week. So doing a history and physical on your children. Every time you meet a child, whether it's in a doctor's office, urgent cares, or ER, you're doing little history and physicals. And always remember HIPAA today. Kids get the same HIPAA. An 18-year-old child can, if they're cognitively aware, can sign their own consents for treatment. Also, we need to get permission from the child to talk to the mother, father, or whoever their caregiver is, okay? So 18-year-old, they can sign for themselves. Now, part of the history and physical is talking with the mom or the dad, or whoever the caregiver is. Making sure that they talk and you tell them, they tell you what you need to know. So keep directing the focus to what's going on right now, okay? Sometimes you have to remember there's cultural awareness. There are some cultures that you can't look at their eyes. That's an invasion into their privacy, or you can't touch them or hug them, giving them space. There are cultures that you need to respect that. So being aware of it. And remember to listen and being empathetic. If you can imagine getting an infant in, let's say they're 6 months old, they've been sick since Monday, they've been to the doctor Tuesday, and they went Wednesday, went to urgent care Thursday, and here it's Friday, now they're at the ER, and the mother's working and she has 2 other kids at home. Mentioning, you must be exhausted. Wow, how did you do all that? You must be running on empty. Just acknowledging what they've gone through to get to you will help that parent feel like they did what they were supposed to do. Because at this point, they have their hands up, they feel like a failure. But what you just said is, but you're here now and we'll take care of you. If any questions, just ask me. I'm telling you, I've had more of a parent hug me when they were leaving to tell me, thank you for listening. Thank you for understanding how exhausted I am. Also, if this parent or this child does not speak your language, do not ask a family member to interpret. Make sure you get a proper interpreter, because the family's going to put their spin on it, their own feelings on what was said. Talk to your kids. Well, number one, whenever you approach a child, you need to get on their developmental level. Get on their eyesight. I sit down next to them on the floor, on a stretcher, in the chair next to them, whatever I got to do. And then I want to start with things like, wow, your sneakers light up. I said, do they run fast? Do they work good? Or they've got a t-shirt on with some comic character, mention it. Or they've got the biggest blue eyes or freckles or curly hair or pretty bows. I'm going to do something, to make them start, oh, okay, she's all right. And then I'm going to ask maybe the older kids, 3, 4, 5. So are you in school? Are you in daycare? What do you like to do the best? Do you like going out? Do you like the playground? Do you like letters? What do you like? And now I've calmed the kid down, and now I'm not this big meanie. And then, of course, using word games and nonverbal and play with these kids. And these kids that were very resistant, stand back, not talking, are now talking to me, especially those a little older that can tell me stuff. If you get a room of people, make sure you know who's going to be talking for the child. I've had a room before COVID where there was 10 adults in it with one kid who had a fever for the last 2 days. So I said, who am I talking to? And it wasn't mother or father. The child was with the mother's sister, so the aunt. So I said, okay, can you tell me what's going on with this child? So make sure you know who, what's going on, and the present illness. If you let them sometimes talk to you about the child, they might go from birth all the way up to 5 years old with everything that's ever happened. So as long as they had a normal delivery at birth, have no medical conditions, then we can go to what's going on today. Of course, we want to know if they're eating good, anything else, any operations, allergies, have they had any medicine, including Tylenol, Motrin, or any, vitamins or supplements? Are their immunizations up to date? I mean, if you have a child is a fever and is in there with a bad cough and they're 8 months old and they have had no immunizations, you could be dealing with something like pertussis. So again, I'm going to wear a mask. I'm going to protect me, and I'm going to protect my emergency room or my doctor's office, whatever, but saying, stay in the room, please. Have a mask on the kid if they come out. I'm going to make sure that everybody's going to be safe. And then I want to know, especially if I'm going to admit these children, any habits. They have a special blanket, a special pacifier, a special toy. What calms that child down? Do they like to suck their right thumb? So I'm not going to put an IV in that hand, right? So things like this are very important. Adolescents getting a sexual history, I usually get the parents out of the room. And I don't have to tell a parent what that child says, unless what they tell me could hurt themselves or others. Because sometimes they're not going to open up in front of mom. I know I was not going to talk in front of anybody with my mother at a teenage age. I mean, she might ground me for life. So it wasn't going to happen. So there is ways that we can. And then again, building up esteem with an adolescent. When we get to that chapter in 2 weeks, we're going to be talking how to do that. And always know who's the boss in the family. Is it mom? Is it dad? And remember, that could be cultural too. So you want a family general history, is there diabetes or heart disease or something in the house, asthma? How are they doing in school? Are they good in school? Because that makes a difference on how they're going to be with you, even taking medicines or getting a treatment done and listening to things. Parent-child relationships. I can tell by walking into a room, an emergency room. In the last 10 years I was in an emergency room. I was one of the primary trauma nurses there, and I love just taking care of the kids and just taking my little pods, as we called them. And I'd walk into the room and the parents, mother, dad, whoever, they're on their phones watching TV, and the stretcher has the sheet off, the pillows off, the little black ear things are thrown all over, the drawers are open, alcohol pads, gauze, culture sticks are everywhere. And I'm like, so what happened here? Wasn't anybody looking? So you know that they have no control on their child. And they're supposed to be coming in because they're concerned about their child, right? Emergency room. So is that kid going to take their medicine? Or am I going to have to do something to tricks that I know to get it done, right? Makes a difference. What do they eat? Any practices that I need to know about? And of course, you're going to look at their overall nutrition. And we do have all those growth charts today that we can look at, which are great. Now, when you examine a child, don't think head to toe, because it's not going to happen. You're going to do what you can do when you can do it. For instance, you have an infant asleep in mother's arms. You know what you're going to do first? You're going to listen to their heart and to their lungs, because you want to make sure that you can listen well without crying and whatnot. And then maybe later you'll do pupils when they're awake, or touching their pulses, etc., listening to their belly. So again, never head to toe on a child. It's as you can. And of course, you're going to be doing it, of course, sometimes focused assessments, depending on where you are. Now, when you examine the child again, most of these kids expect you're going to hurt them. So get on their level, let them know what's going on, and try to be as atraumatic as possible. Parents there, on the parent's lap. You can do so many things, okay? I always use parents, unless it's a spinal tap, and I can't because it's sterile procedure. But besides that, I'll always have parents there helping with me, telling them what I need and how I need it done, etc., etc. You'll be doing all sorts of measurements, etc. Remember, every kid's age, there's different numbers for everything. As when you talk about infant, you only do an apical pulse. Maybe when they're 2 years old, then you can do a radial pulse, okay? You get more accuracy. And your blood pressure cuffs are all different. Infants are born with huge heads and they have smaller chests. By the age of 1.5, their chests should be equal or bigger than their heads. Now, if they're not, something's wrong, right? We're looking at their ears, their throats, their chests, their lungs. Using a visual first always helps with respiratory, and even just looking at the abdomen, you can see what's going on. So first look, inspect, and then auscultate and palpate. And then, of course, looking at genitalia, because you have ambiguous genitalia. I've seen it before. You have a lot of girls that have their vaginas have fused, their labias. So there's very little that you could try to even catheterize. You just put hormone cream in, opens up by itself. It's not a big deal, but it does happen. So also you want to circumcise an uncircumcised infant, and you need to do a Foley cath, right? You can't pull the skin down to some. How are you going to get that catheter in there? So genitalia can be very important. You might need 3 nurses in there to help you to do that one. Of course, looking at the way they're moving, their anus, etc. Reflexes. I can't tell you how many kids I would make their legs bop up in the air and they just thought it was the greatest thing on earth. And then I would let them do mine, and my leg, even if they got it right or not, my leg would bounce up too. Again, doing measurements as we need. Now, one of the things I've told you about is height and weight at birth, right? Take that little board and put it on a kid like this age right here. They're not going to let you do it unless you play with them first. So I go on, I put it down. I said, oh, it just touched me. All right, this is my number. I said, here, hold it. Tell me when it's there now. All right, what's your number? Your number's better than my number. Now we made fun of it. You got an accurate height, and the kid wasn't scared because they really think it's going to come down and smash them. More than one kid ran to the other side of the room when I walked into like some other nurses doing this, because that's what they feel like. They thought it was going to bop them. Dealing with kids, different ages, you go grab a blood pressure cuff, you need to grab the proper size. Do you know we have 00, 000, which is like the size of my finger blood pressure cuffs, all the way up to adult extra large? Which one do you use and where do you put it? And I, most of the time, will put it on the D, the last one, because I can sort of hold the leg, it doesn't hurt as much. I know when I put it on the A, the brachial artery, it squeezes my arm, it hurts. And it does more on your children. Unless you're cardiac, I'm not going to put it there. I'm going to always use your leg. And it's an accurate blood pressure if used with the proper size cuff. And then last thing is all about pain. Now, up to a couple of years ago, we didn't look at pain as well as we do today. We know that many nurses feel that, oh, that's just too much medicine. Oh, it's too much. I can't do that. And what we found is children go to the hospital and all they remember is that they were in pain. So we need to make sure that we assess their pain frequently, that we give the proper doses. There's so many research done. Morphine is probably one of the safest pain medicines we can give because we know proper dosages and we know it works. And making sure we're giving it timely and evaluating, did it work? So in adults, 0 to 10, 0 is no pain, 10 is the worst pain in the world. How much pain are you in? That's what you hear, right? Well, with children, you're going to see faces, Juan Baker, and numeric. Those are the 3 things that you see the most. Not saying you might see something else, but those are the ones I've seen the most. Now, numeric, according to the book, you use it for children 8 and older. Have I used it for younger kids? Oh, yes. But according to the book, it's age 8. Flack. Flack is used for children less than 3 years old. So newborn, 1 and 2, and non-verbal children. You could have an 18-year-old non-verbal cerebral palsy child, and they can't express what's going on, but visually you can see what's happening. you're going to see their face. Maybe it's full of grimacing, okay? Maybe their legs are not even moving, or they're really shaking because they're really hurting. Or you might hear them cry and you can't console them. So FLAC, that's what that means. And a score can be made from it, and it's extremely accurate. Faces is the other one that we do use, and that's those little pictures of little smiles. And children, school-age children, age 3 up to age 8 will use this scale. Most pediatric nurses carry that scale on them, on their badge, so they can show it to the child. Which one do you feel like right now? Acute pain can be due to anything. I think the one that hurts the most, they go to the doctor, urgent care, ER, is ear aches. Ear pain, otitis media hurts. So they're sitting there crying, before I do anything, I'm going to go get some ibuprofen and give it to them, if they've not had it already. Because once the pain medicine kicks in, all of a sudden they're fine again. Kids are resilient. You know, an adult will sit there and still whine, but not a child. You give them something, they feel better, they're going to start drinking, they're going to eat and feel better. When the pain starts, their fever starts again, you're going to see them sit in the corner again and not eat and feel miserable. And you know to give them something more for their pain or for their fever. It could be due to anything. It could be, well, right there, that's your Wong's Baker on the bottom right now. That's where you smile to a little picture. And you know what the great thing about children and their pain scales? They're real. Adults exaggerate their pain. Children never do. And I think that's one of the reasons why I love them the most, because they do tell you what they hurt like. All sorts of pain that there's there. Remember, if a kid always has pain, it's going to affect every aspect of their life, you know, from home to school. And there are all sorts of pain checklists, as I said. And remember cultural differences. There are cultures where you're going to hear daddy say to the little boy, oh, you're not in pain, suck it up, you'll be fine, don't worry about it. And I'm saying, but your child has a broken wrist and we need to put a cast on it. Can I give your child something to put that cast on, please? And when you explain it, they're like, okay, but you know, you have to be sometimes that person who deals with the pain. It's cultural, it's okay. But remember, as a nurse, you're the advocate for this child. Also with pain management, it's just not medicine. Even with adults, you can give medicine, but elevate the head of the bed, give them a pillow to splint their abdomens, you know, give them an ice pack, a hot pack, put music on, distract them, TV, iPads, games, whatever. An infant, give them a non-nutritive sucker, a pacifier. And this kid, you can literally, according to Harvard neurophysiologist, okay, they did a study on morphine versus a pacifier with sugar water on it. They did circumcisions and they found there was no difference between the infant with morphine and the one with just the pacifier. It helps with pain. We use that putting in IVs, doing blood sticks, doing catheterizations, all of this with a pacifier, and it is a self-soother. What this girl's doing, this woman is doing here is kangaroo care. You know, this is probably about a 29-weeker there, about maybe 800 grams at that time. This kid be in the warmer or the isolate, and they're just moving, and their, you know, heart rate's up, and they're just fussy. Put them on mommy's chest, skin to skin. All of a sudden their heart rates go down, their respiratory rates go down, and they go to sleep. It's the most wonderful thing to see. That mother, the sound of her heartbeat does soothe them, and that's called kangaroo care. Remember, with all of those opioids, there's always some ibuprofen or Tylenol to give in between. Make sure we use what we have. Again, using the hot packs, cold packs, using some little bit of numbing cream to start an IV or do a lab work. I mean, this girl's smiling. She's getting somebody to come up and stick her with a needle for lab works in a couple of minutes. Why is she smiling? Because she knows the numbing cream's going to work and it's not going to hurt, right? As I said, all different things that causes pain, from circumcisions to surgery to burn, headaches, braces. It could be sickle cell, could be broken bones, anything. Now, which of the following is an important factor for consideration in understanding the pain experience in children? Anybody? Which one do you think? Anybody?
B.
It is B. And you know why? They don't want the medicine because they don't like taking medicine, or they don't want a shot. So they'll sit there and not say anything because I don't want to take the medicine, but I hurt really bad. And you just want to cry for them, saying, no, it'll be okay. Let me help you. So they sometimes don't. So sometimes you got to look at the kid. If they're grimacing and crying, you know they have pain, make sure they get something, okay? So there you are. Camila, where are you? Nadia? There you are. Okay, I couldn't see you. All right. Making you're still with me. Melinda, are you still with me? The internet working?
I am still with you.
Gotcha. Okay, I'm just making sure you're there. Okay, any questions regarding today's lecture? Okay, what I'm going to do is put up the Kahoots. Everybody played the Kahoots before? Well, go to kahoot.it. Let me find it. There it is. Had some ads pop up. No ads. I don't want ads. So I have some new backgrounds this semester. I think it's pretty good to have a classroom, right? That's where we are. So go to kahoot.it, put in your PIN number, and put in 1099146. So can you pick your faces that are coming up? Or does it just give you one?
I think it just gives you one.
Okay. Because this is a newer thing. It's never had faces like that before.
I have the option to pick.
Oh, okay. All right, let's get going. As soon as we're done with our Kahoots, we're out of here, okay? Week 1. Wow, it's going to go by quick, guys. It goes by quick. From a worldwide perspective, infant mortality in the United States. What did I tell you about infants dying? First year of life, especially in the first 28 days in neonatal stage.
Is it too late to sign up for the Kahoots? I'm so sorry.
No, keep going. Not a problem.
How do I, do you have the code?
Go to kahoot.it and your code is there at the bottom. 1099146.
Okay.
So as I said, remember, we are lacking behind. We're getting there, but we need more to do more work. Has to do with prenatal care, and then of course the care of the infant after birth. The leading cause of death from unintentional injuries in children is what? It means unintentional. It means we didn't want it to happen. It happened and we had no control on it. And that is motor vehicle fatalities. You know, children are put in car seats improperly. They're not rear facing when they should be, or they're front facing too quick. Also, I think the advent of these rear view mirrors came because many children were ran over. In my career, I've seen 4 children run over by a car. I saw 2 kids that ran over that did okay, and I saw 2 kids who didn't do well at all. So I think that's why the rear views came in, but motor vehicle, whether in them or run over by them. And then as children, adolescents driving them, right? What statement is most descriptive of pediatric family-centered care? What is a family? When they're born, this is the only constant in their life. It's as they get older, they reach out and see that there's other families and cultures, but family is always there. It's the only constant that any child has. The major cause of death for children older than 1 year is, that means you're toddlers, right? The dive bomb children, jumping off of couches, trying to jump on the hassock, missing it, bopping the head, screaming. My grandson did that to me. And it's called unintentional injuries. The nurse caring for the child in pain understands that distraction remember, you can give all the pain you want, medicine you want, but you also put distraction there in many different forms. We know that it's going to help that pain. But remember that distraction must be where the child understands it, that developmentally appropriate. Like giving an infant a sticker is not going to do anything, okay? But maybe rattling a little thing, or maybe giving them the pacifier to suck, okay? But a 3-year-old, they're not going to get a pacifier, right? So what does that child that age need? In what type of play are children engaged in similar or identical activity without organization or a mutual goal? Something again we're going to go over next week again, but it was in this week's readings also, so that's why it's mentioned here. And it's called associative. So associative, they're playing together, doing something. Cooperative is when there's a goal in the end, that they're going to do it like playing checkers. Somebody wins in the end, or we're going to build a block and a tower with a flag on top. Whatever the end is, there's a goal. Which statement best describes the process of critical thinking? You went into nursing school and they tell you that you're going to teach you how to critically think. You're like, oh my goodness, what does that mean? Well, if you need something to eat, you go home, you look in the cupboard and you see what you got. You go to the grocery store, you buy what you don't have, you go home and you make it. That's critical thinking, right? Because it's purposeful. It's the goal directive. You wanted something to make and you made it. And that was the goal. What is probably the single most important influence on growth at all stages of development? Nutrition, 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 because they need that to be able to grow for cognition, for brain health, muscle health, nerves. Frequent developmental assessments are important for which reason? Like, why do I want to see how big they're getting? If they're rolling over, turning over, if they're lifting their heads, are they walking yet? Do they have teeth yet? Why do I look at those things? because we can see those delays or deficits. And the best thing about children, they're so resilient. You start early intervention, speech, physical, occupational therapy, and these children turn around and catch up where they should be. Could it be due to poor nutrition? We can better that nutrition so we can identify and take care of it now. Which function of play is the major component of play at all ages? And we know it's sensory and motor activity. That has to do with the texture, has to do with exploring the world in their mouth and moving and playing with it, which promotes creativity, which promotes socialization, which promotes intellectual development, okay? Play, sensory and motor activity, exploring it. 3 children playing a board game would be an example of what type of play? And that's cooperative play. Associative, playing together, but there's no goal in the end. Cooperative is a board game. It's a great description. A goal in the end, playing together. The head to tail direction of growth is referred to as what? And you start with lifting your head and you end up walking by the end of first year. That's cephalocaudal. What does that mean, right? Head to tail. Cephalic. Look at what the word is. So you lift your head and then you're able to get up and turn over and walk and creep. And that's all part of what we call cephalocaudal development. What is the single most important factor to consider when communicating with children? And the child's developmental level, because they're not going to listen if they don't understand what you're talking about. And you need to get on their level so that they are going to listen. So you're not threatening. They're not going to just, tune you out. What 2-year-old child pain assessment tool should the nurse use? Which tool? 2 years old. So 2-year-old is FLAC. At preschoolers, age 3, it turns to faces, okay? That is a really familiar question that I've seen on Hesi's and NCLEXs right there. Know when you change from FLAC to faces, and then when to change to numeric, okay? At 6 months old, an infant's birth weight should do what? And if it's too little or if it's too much, then we need to do an intervention, right? It should double. And what do we do at 12 months? We triple. And then at 2.5 years, we quadruple. The first expected fine motor development milestone for an infant begins with what? There's fine motor and gross motor development. Fine is F fingers. Fine F fingers. That has to do with a voluntary reflex palmogram. It has to do with pincer grasp. You use your fingers. Putting objects in a container and building a block of 2. That's the first year of life with fine motor. The first thing is a reflex. You put your finger in the child's hand and by reflex they close. Then it goes to voluntary. Then it goes to crude pincer. Then it goes to fine pincer, okay? An 8-month-old infant should be able to perform which fine motor skills? After saying that, which one do you think it should? Putting them in containers is 11 months and blocks of 2 is 1 year old. So they're getting that rattle. They're looking at it, they're shaking it, they're exploring it, right? Like, oh, I like that sound. So they do it again. Cognitively being aware. And of course, crude pincer means they'll take like with Cheerios or those little puff balls on the high chair and smush it in their face like that. And then it gets older. They'll go little one by one. The natural physical developmental sequence that most children follow is what? This is gross motor right here. Physical or gross motor. That's that get up and go. What do they do first? Exactly. They lift their head up, they roll over, they creep, they crawl, they cruise, and they walk. Excellent. Very good. The behavior indicates that an infant has developed object permanence. What does that mean? So even though something is not in sight, they know it's there because they just saw it. They're going to go looking for it. That is object permanence. It's that child where you take the toys and put it in the toy chest and you don't think they know where it is or they forget about it. No, they don't. They go get it back out of that toy box as they get older. In general, an infant should triple their birth weight at what months of age? Well, we double at 6 months. We quadruple at 2.5 years. And we triple at 1 year old, 12 months. Very good. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. What do you do first? You have to do a head-to-toe. Well, in that scattered way that you're supposed to. Again, before you do anything to any child, make sure that you do it on that child's developmental age and that you've built up that rapport first, or it's not going to happen. A little bit of time spent will save you a lot of time in the end with children. According to Piaget, toddlers are in the blank developmental stage. Again, we're going to go over a lot of this more next week, but I wanted to introduce you to the theorist. I did give you the handout, so you do have it. And Piaget is all about that sensor and motor. Remember, taking the rattle and then shaking it and hearing it, and then goes back and does it again because they like that. So sensor and motor, exploring their world. Which intervention helps a hospitalized toddler feel a sense of control? I mean, having a kid age 1 to 3 in a hospital or even on vacation is really rough. They're not in their environment. They're not happy. So try to keep the same schedule. Try to keep the same diet if you can, according to their diagnoses, and the same times of feeding, same nap time, same bath time. It does give them that sense of control, and it will be a happier child. All children reach developmental milestones at the same age, yes or no? All children walk by the age of 12 months. Absolutely not. They're all different. My children never walked. At 15 months, they all ran. So absolutely false. They're all different, special, and unique. And that's why I love pediatrics. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for that infant? What do I tell you about infants and atraumatic care? Give them that little pacifier with a little bit of sucrose or sugar on it, and that child's not going to barely feel that they had an injection. And then put that child, that infant, in the mother's arms. They're not going to be bad at all. Which of the following immunizations can be administered to a newborn? Now you're going to see 2 big pages of immunizations, and you're going to say, how am I going to remember all of these? Well, I don't ask you to do that. This one is given at birth, and then we have the ones at 2, 4, 6 months, and 18 months, 15 months. Hepatitis B is at birth. We do give it, or if it's not at birth for whatever reason, the first doctor's visit and that 2 weeks later, they'll be getting their hepatitis B. Normal heart rate for a newborn infant is what? (140 to 160 beats. 60 to 100, that's more like an adult, and 80 to 120, 80 is way too low. So that's not an infant at all. 120 could be an adult with a fever, right? Or dehydrated. What is the preferred site to give an injection to an infant? And that's your vastus lateralis, okay? As infants, we put them in the outer upper thigh and in the parent's arms, have another nurse hold their leg so they don't jerk, and give them that injection, give them a pacifier, and they do really well. The death of an infant under 1 year old with no known cause, what is that called? And we're going to be going over what are those risk factors for those children next week when we talk some more. And it's called SIDS, or sudden infant death syndrome. So we'll be going over that more. A Vietnamese mother of a child avoids eye contact with a nurse considering cultural differences. Why doesn't she look at her? What's going on there? It's all about respect in this culture. So if I see this going on, I might say, why don't you look at me? Do I have like something on my teeth? What's happening here? You know, they would prefer you to ask. It makes them feel better. You know, and you could say, you know, oh, thank you so much. All right, now I can understand if you're not looking at me. I'm not going to worry about my teeth anymore, right? Or something of the sort. They appreciate it to be asked. A child from Mexico is hospitalized for a serious injury, and the father says the child's being punished by God. Why is he saying that? The kid is sick. Again, this is a common health belief in this culture, and you can let them know. You have to say, they're going to believe this no matter what you say. So just understanding this is not going to shock you when this father or the mother or anybody says those things. Which term refers to times in an individual's life when he or she is more susceptible to positive or negative influences? These are part of your key words that you're going to see, on the front of your chapters that you should be looking at. So you know some of these terms that you've never seen before. And it's called sensitive period, okay? What is a characteristic of a pre-operational stage of cognitive development? Now, pre-operational is all about Piaget. It's all about thinking, cognitive awareness. So thinking, what does this child think about? And this is more of your children that are in the toddler preschool age. They have to see it to understand it. They don't figure things out. Nothing's logical yet. They can say that this truck, when you roll it, it makes a noise. Okay, I do it again, it's going to make the same noise. That's thinking, that's concrete, okay? They have to visualize it, hear it, see it. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Well, thinking about Kohlberg, you're thinking about morality, right? And we know Kohlberg's all about actions are good or bad, and there's always a consequence for either good or bad actions, okay? That's Kohlberg. All right, let's see how we did. Number 3, Megan. Good job, Megan. Number 2, Jamie. Whoop, 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 whoop. Number 1, Yaya. I like that, Yaya. Jazz and Jacob. Okay, today's class is over. I'll be sending you the recordings. I'll be sending you the Kahoots. Again, remember, if you need anything from me, want anything, you're not getting something, let me know and I'll get it to you. I'm always here. I haven't abandoned you at all. So if you want something, let me know. Any questions by anybody? We usually give 10 minutes per hour per break. I run straight through, don't give you a